Today we will be talking about sepsis, in particular, the medical management of the critically ill patient. My name is CLee, and I'm an intensive care medicine specialist at Mount Sinai Hospital, University of Toronto. We will review three main objectives for today's discussion. The first will be to provide a definition of sepsis, followed by explanation of the diagnosis of sepsis, and finally, highlight some key management principles and a guideline-based approach. Let's review some of the new and old definitions of the sepsis guidelines. Prior to 2016, the old definitions of sepsis were made up of several different categories. The systemic inflammatory response syndrome, or SIRS, was characterized by the presence of a temperature of greater than 38 or less than 36 degrees Celsius, heart rate of greater than or equal to 90 beats per minute, respiratory rate of greater than or equal to 20 per minute, and a white blood cell count of less than 4,000, greater than 12,000, or more than 10% bands. If the patient had a suspected or confirmed infection with evidence of systemic inflammation, they would be labeled as having a diagnosis of sepsis. And severe sepsis if the sepsis was consistent with greater than or equal to more than one sign of organ failure. If the patient happened to also have cardiovascular collapse with hypotension requiring vasopressors, this was defined as septic shock. Since 2016, both the definition of sepsis and septic shock have changed. Based on our current guidelines, sepsis is defined as a life-threatening organ dysfunction due to a dysregulated host response to infection, while septic shock is a subset of sepsis in which an underlying circulatory and cellular or metabolic abnormality is found and profound enough to substantially increase your mortality risk. Let's now move on to looking at the diagnosis of sepsis. If a patient with an infection presents with increased respiratory rate, altered level of consciousness, and mild hypotension, this may indicate to the clinician that there is a warning sign that this patient may deteriorate and even progress to life-threatening septic shock without aggressive resuscitation. Based on our most recent guidelines from 2016, the current identification criteria for sepsis includes an acute change in the total sequential organ failure assessment, SOFA score, of greater than or equal to 2 points as a result of infection. Baseline SOFA scores can be assumed to be 0 in patients without pre-existing organ dysfunction. A SOFA score of greater than or equal to 2 is associated with a mortality risk of approximately 10% in the general hospital population with suspected infection. Of note, patients with suspected infection that are at high risk of deteriorating can promptly be identified at the bedside using the Q-SOFA. This consists of the three following criteria: a Glasgow Coma Scale of less than 15, respiratory rate of greater than or equal to 22, or a systolic blood pressure of less than 100 millimeters of mercury. Based on the 2016 guidelines, septic shock would then be defined as evidence of persistent hypotension requiring vasopressors to maintain a mean arterial pressure of greater than or equal to 65 millimeters of mercury and evidence of lactate greater than 2 millimoles per liter. This is despite adequate volume resuscitation. If these criteria are present, the hospital mortality is in excess of 40%. Let us now move on to some of the key management strategies in cases of sepsis and septic shock. When we look at the surviving sepsis guidelines, managing sepsis requires attention to both evidence of infection, which requires early institution of antimicrobial therapy, diagnosis of infection, and source control, and concurrently, we must manage the sepsis-induced tissue hypoperfusion, which essentially means resuscitation and hemodynamic support. The goal of this would be to restore hemodynamic stability and tissue perfusion, as well as institute appropriate physiological support to prevent further tissue injury. Since 2019, the Surviving Sepsis campaign put forth key action items that need to be completed within the first 3 and 4 hours that a patient presents to hospital. The first hour 1 bundle must be completed within 3 hours of presentation. This includes some basic blood work, including measuring a lactate level and obtaining blood cultures prior to the administration of antibiotics. In terms of management, broad-spectrum antibiotics should be started as soon as possible, as well as an attempt at fluid resuscitation with at least 30 mL per kilo of crystalloid for patients that are hypotensive or have a lactate of greater than or equal to 4 millimoles per liter. Vasopressor should also be applied for those patients that are hypotensive and do not respond to initial fluid resuscitation, with the goal to maintain a mean arterial pressure of greater than or equal to 65 millimeters of mercury. In the event that the hypotension is persistent despite fluid administration, or if the lactate is greater than or equal to 2 millimoles per liter, patients must be reassessed frequently for volume status and tissue perfusion. We should always remeasure a lactate, especially if the initial lactate is elevated. All of this should be completed within the first 4 hours of presentation. It's very challenging to talk about sepsis and not talk about fluid resuscitation, but there is much debate as to what kind of fluid should be given during the resuscitation period. Our two main options are essentially crystalloids and colloids. When we look at crystalloids, the primary preferred fluid would be a buffered solution such as lactated ringers over something like normal saline or 0.9% sodium chloride. The primary reason is because there are increasing evidence to suggest that sodium chloride solutions may potentially increase the risk of renal injury. When we look at colloids, crystalloids are always preferred over the institution of colloids. In particular, there is now currently no evidence for use of artificial colloid starches. However, albumin is still indecisive and may potentially be useful in selected patients, and we'll talk more about this in the coming slides. When we look at the Surviving Sepsis Campaign guidelines on fluid therapy, crystalloids are still recommended as the fluid of choice for initial resuscitation and subsequent intravascular volume replacement in patients with sepsis and septic shock. Please note that the use of hydroxyethyl starches for intravascular volume replacement in patients with sepsis or septic shock is not recommended. So when exactly can you administer albumin? The use of albumin is suggested when patients require substantial amounts of crystalloid. We would recommend the use of albumin based on the guidelines in those patients with a history of cirrhosis or patients with hepatorenal syndrome. Albumin can also be used as an alternative in patients after several liters of crystalloid have been given for fluid resuscitation. Based on our best evidence, we would not recommend giving patients with traumatic brain injury any albumin. It has been associated with worsening outcomes and increased mortality. Based on the Surviving Sepsis Campaign guidelines, antibiotics should be instituted as soon as possible. From 2013 and data from 2006, it's very clear that every hour in delay of administering the appropriate antibiotics will lower a patient's survival by approximately 7.6%. The goal here would then be, as soon as you're able to finish drawing cultures, antibiotics should be instituted immediately. Looking at Surviving Sepsis Campaign guidelines for vasopressors, norepinephrine should be used as the first-line vasopressor of choice. Vasopressin or epinephrine can then be added to meet potential mean arterial pressure targets. Vasopressin can be added to decrease norepinephrine usage. In general, although dopamine is a vasopressor, dopamine should only be used in select patients that have a lower risk of tachyarrhythmias or present with bradycardia. Dobutamine should be used in patients with ongoing hypoperfusion despite fluid resuscitation and vasopressors. If adequate fluid resuscitation and vasopressor therapy is able to restore hemodynamic stability, the guidelines would suggest against using IV hydrocortisone to treat septic shock patients. If this is not achievable, then the guidelines would suggest the use of IV hydrocortisone at a dose of 200 milligrams per day. Let's now review the overall management of patients presenting with sepsis. The immediate goals would include identifying a source of infection, initiating early broad-spectrum antibiotics, as well as ensuring adequate IV access for fluid resuscitation. Clinicians should also conduct baseline lab work including a lactate and arterial blood gas. And if one has not been inserted, a Foley catheter should be inserted to monitor urine output. In the first 6 hours, lactate and central venous gases should be measured serially, as well as an ongoing assessment for fluid or vasopressors in order to maintain a mean arterial pressure of greater than 65 millimeters of mercury. If a potential source of infection has been identified, then plans should be made to try and obtain source control. Finally, in the first 24 hours, the goals would be to achieve adequate source control, initiate stress ulcer prophylaxis, and in patients that require mechanical ventilation, to institute lung protective strategies, including low tidal volume ventilation. All patients should also be managed with deep vein thrombosis or DVT prophylaxis. In summary, there is a high mortality from sepsis, anywhere between 30 to 50%. Early clinical recognition is key, followed by source control and empiric antibiotics. Early fluids and antibiotics will save lives, while prolonged septic shock, in particular seen as unrecoverable organ failure, is still considered a terminal illness. Thus, discussing goals of care early in the course of management is very important. Thank you.